So, first of all, I would like to welcome you to this webinar this evening, you, the participants, and the faculty. The topic today is on the involvement of personalized pharmacological treatment for BPH LUTS. And without any further delay, I would like to introduce to you the faculty that is with us this evening. It's Malte Rieken from Zurich, it's Matthias Oelke from Gronau, and it's Paolo Capogrosso, not from Milan, but from Varese. And each of those presenters will cover several aspects on this, what I believe, quite interesting topic. The schedule is as follows. We have 15 minutes per presenter. We will not have a discussion between the talks, but at the end of the talks, we will have a discussion for 10-15 minutes. And the webinar is accredited with 1 CMA points. I would like to emphasize that this activity is supported by an educational grant of GSK. And in doing so, I would like to ask now Malte Rieken from Zurich to give us some ideas on what are the most robust response predictors of pharmacological treatment and update on the available evidence. Malte, please, the virtual floor is yours.
So with some delay, I also like to welcome you to this webinar. And my name is Malte Rieken. I'm a urologist from Switzerland. And I want to talk to you about what are the most robust response predictors of pharmacological treatment. And this is actually an update on the available evidence. And so this is my disclosures. And first of all, I want to go into the question, why do we need predictors of response of pharmacological treatment? We know that pharmacological treatment is actually the mainstay of LUTS treatment. However, it is crucial that we try to individualize our treatment. And that's the reason why predictors of response are helpful in tailoring the treatment we are approaching with our patients. Then, of course, the question is, what kind of predictors are available? And I want to go through some of these, like intravesical prostatic protrusion, age, IPSS, Qmax, prostate volume, PSA, and PVR. And in the end, I want to provide some summary. So what about intravesical prostatic protrusion? This is something we can easily measure ourselves with the ultrasound. And several studies were able to show that intravesical prostatic protrusion is a nice non-invasive parameter to estimate obstruction. Of course, pressure flow studies, urodynamics are better, but still it's kind of helpful. And what studies could show, for example, related to pharmacological treatment is that an intravesical prostatic protrusion more than 10 millimeter is associated with a successful trial without catheter under alpha blocker after urinary retention. So if you have an IPP lower than 10, then the chances are around 80% as compared to a higher intravesical prostatic protrusion. And on the other hand, it's also a nice parameter for the response to alpha blocker treatment. For example, in this scale, you can see from a study which has been published a couple of years ago that related to IPP, the response to treatment to tamsulosin can be variable, which means that those who are responding have a lower IPP, while those who are not responding have an IPP of 10 or more millimeters. So IPP indeed one of the well-known parameters. Then I want to move on to the combination of parameters, which are baseline variables. So there have been several studies showing that baseline variables have an impact on progression and response to treatment. And if we look at the timeline, we know that the Olmsted County study, it's an old study involving various parameters, could show that acute urinary retention and also LUTS surgery are strongly related to baseline variables such as age, severity of LUTS, low Qmax, increased PVR, and high PSA. Then additional evidence was provided by the PLES study, which is a study comparing finasteride and placebo, and it could also show that a baseline PSA, for example, of more than 1.5 nanogram per milliliter is a predictor of long-term change in LUTS and flow rate. In addition, we have the famous NTOP study. I don't want to go into the detail, but here again, baseline parameters such as prostate volume, PSA, Qmax, and PVR are predictors of a greater risk of BPH clinical progression, usually defined as a composite endpoint of various parameters. In addition, we have data from the LUTS trial, which also could show that there is a higher risk of deterioration of IPSS, acute urinary retention, or surgery if the PVR is higher and also the prostate volume is higher. And in addition, we have data from the COMBAT study, also well-known and well-described data, which once again could confirm that baseline parameters are predictors of response to medical treatment in patients who are undergoing treatment for their LUTS. But the question is, if we look at study data, and these are data from the COMBAT study, what can they tell us? For example, let's pick one point. Let's take this study point, which is a patient taking the combination dutasteride and tamsulosin at 24 months. And the question is, what information is provided by these data? And if we look at it, it shows us that the adjusted mean change from baseline is minus 6.2 in this specific combination arm. And the average baseline characteristics of all patients included in the study in this arm are age around 66, IPSS 16.6, PVR 54, and so on and so on. However, usually our individual patients, they are not exactly the mean of the inclusion criteria of those studies. And that's actually the challenge. So in the end, we have those mean change from baseline for a patient with the mean baseline characteristics, but the study data, they cannot tell us what kind of information on treatment response is related to individual baseline factors. For example, if you have someone who's taking the combination treatment, but his PVR, for example, is higher than the mean PVR in the study, how does this individual patient then respond to the combination treatment? And in this context, study data have clear limitations. Based on these study data, several authors were looking into predictive modeling studies in BPO and LUTS. And what the authors were looking at are various baseline parameters related to the prediction of outcomes. So in this busy slide, let's start, for example, here with the 2006 label study. So what we can see, the authors were taking as a data source the dutasteride data from a phase 3 trial. They have a quite huge sample size, and they were looking at the prediction of acute urinary retention in men treated with the placebo or dutasteride. And what the authors could see that study parameters associated with the prediction of this outcome risk are, for example, IPSS, prostate volume, PSA, Qmax. Then looking at some other studies, for example, the risk of surgical intervention, which is, for example, an observational study. Also here we can see once again that IPSS, prostate volume, PSA, and Qmax at baseline are strong predictors of surgical intervention. And for example, the latest study, which I will show you in a second, also combined study data from several studies and was also looking at various baseline data as predictors for response of medical treatment. So if we go further into the topic, and if we look at so-called multivariable prediction models, it means that we take various baseline parameters into equation and we try to individually predict whether the patient and to which kind of degree the patient is able to respond to a certain kind of medical treatment. And in this recently published study, the authors were developing a predictive model to project the effect of placebo, tamsulosin, dutasteride, and the combination of tamsulosin and dutasteride on change in IPSS from baseline as well as cumulative incidence of acute urinary retention and BPH-related surgery up to 48 months. And this actually are models which include baseline characteristics which define patient risk of disease progression as predictors. So something where you look at individual data to predict outcomes. What kind of studies were put into the analysis? So the authors, they included data from 9,167 patients. And these data were from the COMBAT study, so the well-known combination study of tamsulosin and dutasteride, as well as 3 phase 3 dutasteride monotherapy studies. And here you can see the details of those studies, which I don't want to go into precisely. However, you can see that it's a huge cohort of patients where the authors were looking at. And this is the outcome of these are the parameters which were taken into the equation of a multivariable prediction model related to IPSS. And if you look at the relevant covariates, we can see that the IPSS at baseline time, the kind of treatment, and once again, time in months as an interactive term, were the most relevant parameters when predicting the IPSS as relevant outcome parameter. What about the risk of acute urinary retention or surgery? Here we can see that various covariates have an impact on outcomes, while for the IPSS, only a couple of them were relevant. Here we have much more like treatment, baseline prostate volume, baseline Qmax, baseline residual volume, PSA, age at treatment start, baseline PSA, as well as alpha blocker taken in the last 12 months. So these are all parameters which were then put into the model to see how they can predict an individual response. So what, if you put all those data together, what happens? What kind of prediction system can we have? So on the one hand, we can have very complex tables on the left-hand side, or, for example, we can end up with a nomogram. Nomograms we know very well from oncologic topics. However, in this context, it is clear that the table is something which is not very user-friendly. Everybody can appreciate it looks very complex. And also a nomogram is sometimes not that easy to use, especially if we would need 4 different nomograms, because we need one for placebo, one for the alpha blocker, one for the 5-alpha reductase inhibitor, and one for the combination. And so the authors, they were able to develop an online prediction model, which is an online tool. And with this one, you very easily can put in the parameters of your patient. So these are the baseline parameters. And then the system automatically, on the one hand, shows you the estimated IPSS trajectory, as well as the estimated risk of acute urinary retention or BPH-related surgery, depending on treatment arm. So this is an online tool, this is an online model where you actually can visualize the estimated response to tamsulosin, dutasteride combination, or placebo, which means no treatment, for any individual profile having any possible combination of covariates. The caveat is that currently this model is not has not been approved for clinical use. However, I think it's something we can really look forward to using, because it is something which is helpful in counseling our patients. So here we have this BPH tool, which can really help us in individually predicting treatment response. To summarize, we can say that various response predictors of medical treatment have been described. However, a post-hoc analysis of larger studies often seems to be insufficient to describe the complex interaction between various parameters. Multivariable models, such as the one I was showing you, seem to most appropriately reflect clinical reality, because most of our patients don't fall into the mean inclusion criteria of the studies. In addition, the multivariable models, they reflect the interaction of parameters, which also reflects the clinical reality in our patients. And if we want to look at the future, I think it's still important that future studies should analyze the utility of these models on outcomes as well as on clinical decision-making. Thank you very much for your attention, and I'm looking forward to the discussion.
Well, great. Thanks a lot for the presentation. It's actually quite a long history from the initial identification of some markers to this online tool. And I think it was a great presentation. And as I said, by the end of the talk, we will have a common discussion of all three talks. And I would like to invite all the attendees to use the Q&A feature on the screen to send us some questions. And without any further delay, I would like to hand over now to Matthias Oelke from Hanover, Grona actually, to give us his ideas on the most recent data on how to do a decent diagnostic workup in these patients. Matthias, the floor is yours. Thank you for joining us.
Yeah, Stefan, thank you very much. I hope you can see my slide presentation. I can see it on my screen. Can you see it?
Yes, we can see it. Thank you.
Okay, thank you very much for the feedback. And you can hear me, right?
We can hear you fine. Thank you.
Okay, thank you very much. So I can start my presentation. So when we want to use the models that Professor Rieken just told you, we need some baseline parameters. And he has mentioned some of those, and I would like to guide you through the EAU guidelines, and I will show you that these baseline parameters are much needed and are also recommended in all patients. So we don't use abnormal parameters to put it in the prediction model, to put it in the BPH tool. This is real data which we daily assess in these patients. I have some potential conflicts of interest, but my presentation was completely independent on these associations with the other pharma companies. So when we have to assess a patient, we like to use the EAU guidelines on non-neurogenic male LUTS. And you can see the image of the guidelines on the left side. And currently the chair is Stavros Kravas, a good friend of mine from Greece. So we want to assess the patient, and the tests which we use are useful for the diagnosis, but also for the monitoring, assessing the risk of disease progression, but also the treatment planning and the prediction of the treatment outcome. So when we have a patient, an individualized patient with LUTS, we aim to do two things: to identify the diagnosis, that's male LUTS, LUTS BPH, but also differentiate this diagnosis from differential diagnosis from other diseases. The second aim is to define the individual clinical profile, including the risk of disease progression in men with male LUTS, in order to provide appropriate, most modern care. Let's have a close look to disease progression. BPH in general is a progressive disease that includes worsening of symptoms and disease-specific quality of life, deterioration of urine flow, for example, Qmax, and also increase in prostate volume. What can happen is acute urinary retention and BPH-related surgery, but we must not forget other complications like bladder stones, recurrent urinary tract infections, urinary incontinence, renal insufficiency, and other types of bladder dysfunction. So we always have to keep in mind that BPH, or the patient in front of us with BPH LUTS, may progress over time. So what are the risk factors? And Professor Rieken has already mentioned those. In all studies, in epidemiological studies, but also in trials, we always have the same risk factors. They're always the same. It's advanced age, symptom severity, decreased urine flow, elevated prostate volume, increased PSA concentration, and increased post-void residual urine. However, the threshold values for stronger disease progression or lower disease progression vary within the epidemiological trial or the study. And I'm showing you here the clinical trial data of the MTOP study, where 737 were treated with placebo and were followed up 4.5 years. And again, the same risk factors: older age, and in this case was 62 years above, higher PSA, more than 1.6 nanogram per milliliter, higher prostate volume, 31 cubic centimeters, lower Qmax, 10.6, higher IPSS, more than 17, and higher PVR. These are the mean values of the entire study population. So that doesn't mean that everybody older than 62 has an increased risk of disease progression, but the combination of these factors with the different thresholds make this a risk factor. When you see here on the right side, you can see that the big majority of these patients who were treated with placebo had a symptomatic progression. That means an IPSS increase of 4 points or more. Some people had a clinical progression. That means, for example, renal insufficiency, urinary tract infections, bladder stones, and so on. And 12% of the study population of the MTOP study had acute urinary retention. But these risk factors and these chances of disease risk progression may vary between the different studies. So what do we have to do? Let's be easy and just take the EU guidelines on male LUTS, and you will see the assessment algorithm on the left side. And you can see easily, and I'm enlarging a little bit, what are the key parameters to evaluate the patient. It's the history, symptom score questionnaire, urinalysis, physical examination, also with digital rectal examination, PSA concentration, and post-voidodigital urine, and also, in some cases, frequency volume charts. These are the recommendations based on the evidence that's published in the latest EU guidelines on male LUTS. But given the complex etiology of LUTS, a proper evaluation is a key to adequately guide the management. So we have to evaluate all these parameters in each individual patient. In many cases, the urologist is the only or the major treating physician, so therefore we have to differentiate this male LUTS from other diseases. We increasingly know more about the recommendations that can benefit a patient consider their individual characteristics. So it's now going to individualized medicine because we have to determine all the risk factors and all the thresholds in these individual patients. And as you certainly know, the era of one size fits all is over, especially when you look into the treatment. Not everybody is fit or suitable for an alpha blocker only. First thing is how to assess LUTS, lower urinary tract symptoms. Two possible ways, the history and/or questionnaires. And by both of these tools, you can evaluate, is it a patient with only or predominant storage symptoms? Is it only voiding or predominant voiding symptoms, or are these post-micturition symptoms? Just pick the storage symptoms. When you have a patient with urgency, frequency, nocturia, and urgency incontinence, and if he all has these characteristics, we would classify this patient as an overactive bladder patient, and I think you agree. But the big majority of male LUTS patients have a varying amount of voiding symptoms, storage symptoms, and also post-micturition symptoms. And we have to be aware that all the symptoms are unspecific. They do not only originate from the prostate, but they might originate from the bladder, prostate, urethra, pelvic floor, from the nervous system, from the ureter, and from the bowel. So sometimes it's hard to differentiate where the symptoms come from, but we can separate this patient as storage patient, voiding patients, post-micturition patients, or the combination. So understanding the patient habits and existing comorbidity will help to drive individual recommendations. So we have to know what is the patient, what does the patient, what problem has the patient, and how big is the problem. A self-completed validated symptom questionnaire should be obtained to objectify and quantify LUTS. I will show you one later. Bladder diaries are sometimes useful, especially when we evaluate nocturia and/or storage symptoms. And sexual function should also be evaluated, and we should use then the International Index of Erectile Function. This is the most prominent and the most popular questionnaire. We know the importance about medical history, but it's often unrealistic, especially in private practice, to complete 2, 3, 4, 5 questionnaires. So the most of the evidence that we obtain from the patient originates from the talk of the doctor or urologist with the patient. In the EU guidelines, it's recommended to use symptom questionnaires especially validated symptom questionnaires. And the most popular, the most known one is the International Prostate Symptom Score, the IPSS. This is a questionnaire which you can see on the left side. We have 7 symptoms question and 1 quality of life question. Each symptom question you can answer with 0 to 5, making an overall count between 0 to 35. So you should use symptom questionnaire in all patients. We should use the IPSS questionnaire, not only because it's always recommended in the guidelines, but it has always been used in clinical trials. It has a recall period of 4 weeks. Taken together, the count of the first 7 questions, we can have an overall count of 0. There are no LUTS. Mild LUTS is a count between 1 and 7. Moderate LUTS 8 to 19, and severe LUTS 20 to 35. We can quantify storage, voiding, and the combination with the questionnaire, so we can gross classify the patient. And what we know is that the LUTS severity goes along with the quality of life. And what you know is a treatment recommendation. An active treatment recommendation is if you have a quality of life of 3 or more. So what does the EU guideline tell you? The recommendation is take a complete medical history for men with LUTS. Strong recommendation. So take a history. It's not based on much evidence, but it's a general recommendation for every patient. What is said about the questionnaires? Questionnaires are sensitive to symptom changes. Symptom scores can quantify LUTS and identify which type of symptoms are predominant. This is just what I told you. However, these questionnaires, especially the IPSS, is not disease specific. So it's not a BPH only questionnaire. It's gender unspecific. Same women and men in the same age group have the same IPSS scores. So it's not male specific and it's not age specific. But it's recommended to use validated symptom score questionnaires, including BARDA and quality of life, during the assessment of male LUTS and for the re-evaluation during and after treatment. Strong recommendation. So it should also be added by diaries, and it says use bladder diaries to assess male LUTS with a predominant storage component or nocturia, and tell the patient to complete a diary of 3 days or even longer. Electronic diaries might be more beneficial, but there has been no validated electronic diary on the market. It's only a research tool until now because it's a medical product and it's very expensive to validate these electronic diaries. Digital rectal examination of the prostate can be done by, or determination of prostate volume can be done by digital rectal examination or by transrectal ultrasound. And what we know, the rectal examination is the simplest and easiest way to determine prostate volume, but truss measurement, as you can see on the right side, is more accurate. There's an underestimation of prostate volume by digital rectal examination with increasing truss volume. The bigger the prostate is, the more we underestimate it with the fingertip examination. And there are models that use visual aids, and I will show you some of those now. The importance of the individual prostate volume, because prostate volume is a strong predictor of disease progression. You can see the results of the MTOP study, and you can see the results of the 737 patients assigned to placebo. And when we take the mean value of the prostate volume, that was 31 cubic centimeters or milliliters, you can see disease progression. That's the incidence of clinical progression is significantly different for patients with a higher prostate volume. And the same is true for overall progression, IPSS increase, acute urinary retention, and invasive therapy. So it indicates that somebody with an increased prostate volume has an increased risk of disease progression. And this is what you can see, probability of BPH progression with a big prostate volume or smaller prostate volume, you see significant differences according to the baseline parameter. So what does the EU guideline tell you? Perform a physical examination, including digital rectal examination in the assessment of male LUTS. It's a strong recommendation. And some, let's say, unexperienced urologists or GPs or other specialty groups cannot judge the prostate side. And we can give them a visual aid. And you can see here two examples. That's a golf ball, and the golf ball has a volume of about 40 cubic centimeters. And if you take a ping pong ball, it's also increased. It's bigger than normal prostate. It's at 33 or 34 cubic centimeters. So this is just a rough estimation to determine prostate size if you have an example like the golf ball or the ping pong ball. Next thing we have to take is a PSA measurement. And PSA is a glycoprotein specific for men and also the prostate. And we use it for exclusion of prostate cancer, for estimation of prostate size, and also for the judgment of BPH progression, for example, prostate growth, symptom deterioration, the risk of acute urinary retention, and need for surgery. You can also see, again, for the MTOP study, and here in the PLES study, that was finasteride against placebo, that people with a higher PSA value or lower PSA value, they have a different overall progression. Overall progression is significantly higher with a higher PSA, but also a symptomatic progression, acute urinary retention in the basis therapy. So it tells you that an enlarged and increased PSA value will give you like significant disadvantages in the clinical course. The same is true for the PLES study, where they divided in the lower third, 0 to 1.3 nanogram per milliliter, 1.4 to 3.2, 3.3 to 12.0. And you can see somebody with a lower PSA concentration or maybe a lower prostate volume will decrease in symptoms over time, whereas the patients with the higher PSA values or the higher prostate volumes do not benefit from the treatment and will deteriorate alone without any further treatment. So what does the EAU guideline tell you? You should measure PSA. If a diagnosis of prostate cancer will change management, it's clear it's a differential diagnosis to prostate cancer, but also measure PSA if it assists the treatment and or the decision-making process. And then we go to disease progression, and then it's important again. And this is true for even relatively low PSA values, like 1.4 nanograms and sometimes 1.6 nanogram per milliliter. Then uroflowmetry. Uroflowmetry can detect in general voiding disorders. The key parameter is the maximum urine flow, which you can see that's the highest flow here when you record it as a graph. Repeat the uroflowmetry if you have abnormal values, that's self-speaking, and the low Qmax can be caused by bladder outlet obstruction and or detrusor underactivity, but you can only determine voiding dysfunction, but you cannot determine if it's bladder outlet obstruction or detrusor underactivity. What does the EAU guideline tell you? Perform uroflowmetry in the initial assessment of male LUTS, a week recommendation, and perform uroflowmetry prior to any medical or invasive treatment as a baseline parameter, and that is a strong recommendation. The last parameter I would like to tell you or introduce you is post-void residual urine. You can do it either by ultrasound or by catheterization, and I think everybody does it of you by ultrasound measurement, as you can see on the left side. It's a well-known factor of disease progression, and if you see the MTOP study again, you have the higher values. The threshold again is 39 milliliters, and if you have 39 milliliters or more, then you have a higher chance of disease progression compared to lower PVR volume. A large PVA may indicate a poor response to treatment, especially watchful waiting. It's a key measurement for patients using antimuscarinics, because if you have a high PVR, then you are likely to produce acute urinary retention if you use antimuscarinics. And there's no PVR threshold for the treatment decision. This is a research priority. And again, this is a medium value, but this is not always in every study the exact threshold value. So what does the EAU guideline tell you? You should measure PVR in the assessment of male LUTS. It's a weak recommendation, but it's still recommended. My last slide, and this is also the summary, we should do a careful assessment of men with LUTS, and this is valuable to diagnose and quantify male LUTS. This is important to separate male LUTS from other diseases and also to identify people with a risk of disease progression. In order to do so, we can use the recommendation of the EAU guidelines on male LUTS. And all the baseline investigations which are recommended, and I've just mentioned to you, are used in the BPH tool. And I'm showing you on the right side the parameters which you can change online. It's age, IPSS, prostate volume, PVR, Qmax, PSA, and previous alpha blocker use. And these are the parameters which you can use for individualized outcome measurements. You can predict the individual change and the individual risk of disease progression with patients showing here different baseline parameters. So I'm done with my presentation. I would like to thank you very much, and I'm open for discussions later.
Well, also from my side, thanks a lot for giving us this overview and this in-depth view on the EAU guidelines, and to emphasizing the role of these guidelines and how necessary it is to follow those. Thanks a lot. And I will hand over directly to Paolo Capogrosso from Varese to give us his ideas on the evolution of individualized pharmacological treatment, some key highlights. Paolo, the floor is yours. Thanks a lot for joining us.
Thank you, Professor, for the introduction. I'm glad to be part of this tremendous faculty. So I think you should now see my presentation. So my talk will be mainly focused on the key evidence of the evolution of the individualized pharmacological treatment in BPH LUTS patients. I have no conflict of interest. So first of all, why we need to tailor the treatment for BPH LUTS according to patient's profile. The first thing is to optimize treatment efficacy and reduce the risk of disease progression. And the second important thing is to reduce the risk of treatment-related adverse events. These are the clinical variables that should drive the BPH personalized treatment in these patients. So first of all, comorbidities, cardiovascular disease, metabolic syndrome, obesity, then prostate volume, of course, symptoms, storage or voiding, prostatic inflammation, and sexual function. So one of the first important steps in the history for treatment of BPH LUTS was the advent of uroselective alpha blockers, which were drugs able to be very selective for the urogenital tract. And this important feature was able to reduce the risk of cardiovascular adverse events, because of a lower effect on the vascular district as compared to the former doxazosin and trazodone that were used before. So as you can see in these studies from the early 2000s, uroselective drugs such as tamsulosin and alfuzosin were less commonly associated with episodes of symptomatic hypotension, and also with lower risk of dizziness, which is another important adverse events that can be due to vascular dilatation, systemic vascular dilatation. And for these reasons, also treatment with tamsulosin has been shown to be safe in patients who are taking concomitant medication for arterial hypertension, since there were very few cases of blood pressure reductions during concomitant treatment. Therefore, the EAU guidelines suggest to use uroselective drugs such as alfuzosin and tamsulosin in patients with cardiovascular comorbidities and or vasoactive co-medication. Moving forward, also metabolic syndrome, as you know, has been largely associated with the BPH and lower urinary tract symptoms. And along with the metabolic syndrome, most of the patients may have hypogonadism. And there are several data showing that hypogonadism is associated with worse symptoms, and that there are data showing that the treatment of hypogonadism with testosterone replacement therapy is associated with a significant improvements in urinary symptoms and sexual function. And for this reason, this is something that should be considered in patients with hypogonadism and BPH. Moving forward to prostate volume, we have already listened a lot about prostate volume by the previous speakers. We know that finasteride and dutasteride had shown in randomized clinical trial their effect in reducing the risk of acute urinary retention and need for BPH surgery. And after the advent of the milestone studies such as the MTOP study of combination therapy, showing that combination of finasteride and doxazosin was better than placebo in reducing the risk of clinical progression, and also the COMBAT trial showing that tamsulosin and dutasteride was more effective in combination as compared to single treatment in reducing the risk of clinical progression. But we have to focus on the inclusion criteria of this study, since these studies mainly include men with an IPSS score higher than 12, so patients with moderate severe symptoms, a PSA higher than 1.5, and a prostate volume higher than 30. So all these effects should be considered according to this inclusion criteria. And indeed, the sub-analysis of the COMBAT trial showed that the effect of combination therapy was extremely significant, especially in patients with a prostate volume higher than 40 milliliter. And for this reason, this is the threshold that also the EAU guidelines consider to be used for suggesting a combination treatment with alpha blockers and 5-alpha reductase inhibitors. Moving forward, storage symptoms is another important factor to consider, since many men with BPH and LUTS may be bothered by significant storage symptoms along with voiding symptoms. And in these patients, the treatment with antimuscarinic drugs could be significant in reducing, in improving their quality of life. And therefore, this is something that should be considered also in association with alpha blockers, since it has been demonstrated that it is superior than single treatment alone. Then prostatic inflammation, as most of you already know, prostatic inflammation is something that is almost always present in patients with BPH. These are the findings from the REDUCE trial, where patients have been biopsied for the BPH and IPSA, and they show that in 77% of cases there was chronic inflammation, and that chronic inflammation was associated with worse urinary tract symptoms. And even more interesting, in the MTOPS study, in the sub-analysis of the MTOPS study, looking at prostate biopsy markers of inflammation, these markers were significantly higher in patients with a higher risk of clinical progression. So severe inflammation is a very important factor to consider. And we know that in this kind of patients, there are meta-analysis of randomized trials showing that the combination therapy of the exanic extract of Serenoa repens along with the alpha blocker could be more effective than monotherapy in improving lower urinary tract symptoms. Finally, sexual function. We know that rectal dysfunction and LUTS more frequently are very frequently associated in these patients. And the risk of erectile dysfunction increased with the increase of symptom severity. We know also that PDE5 inhibitors have proved in several randomized clinical trials to be effective in improving LUTS and erectile function, and especially tadalafil 5 milligram daily. So this is again something that should be considered, especially in patients suffering both from erectile dysfunction and moderate to severe lower urinary tract symptoms. And this is important because when looking, as shown in this systematic review, when looking at patients' values and expectation and preferences regarding treatment of BPH LUTS, they stated that avoiding sexual side effects is something very important to be considered when prescribing a pharmacological treatment. We have to know that because we know that several drugs in this case are associated with a negative impact on sexual function, especially alpha blockers. We know that can cause a can have a detrimental effect on ejaculation with anejaculation or retrograde ejaculation. And this is something that it is less common with the non-selective compounds, doxazosin and terazosin. Moreover, 5-alpha reductase inhibitors have been also associated with a significant risk of hypoactive sexual desire and erectile dysfunction in several randomized clinical trials, without any difference between the two drugs. And even more important, the combination of 5-alpha reductase inhibitors along with alpha blockers could be associated with a greater risk of sexual side effects as compared to monotherapy alone. So in conclusions, we know also, as we have listened from the previous presentations, that we have to consider several preoperative factors when deciding which kind baseline factor when deciding which kind of treatment to suggest to our patients. And basically, I think that the main thing that we should focus on are, of course, prostate volume and all the other clinical factors that have been highlighted before, but also to consider sexual function and the comorbidities such as cardiovascular disease and metabolic syndrome, along also with prostatic inflammations. All this information should be used to suggest to our patients the best tailored treatment to achieve the best quality of life for the patient. Thank you for your attention.
Well, thanks a lot for the nice talk, also emphasizing that there are more factors than just the urological factors that influence the decision treatment, like metabolic syndrome, inflammation, and the issue around sexuality. Well, thanks a lot for giving this talk. And now we have exactly about 10-12 minutes time for discussion. And I will start off with a question that comes from the floor. Maybe that's something for Matthias. What do you think the role of findings like secondary changes on the bladder, like thickening, diverticular, and trabeculations, in prediction of medical management of male LUTS? So how would you manage a patient with diverticular, with probably a thick bladder wall? Would you manage these patients differently? Maybe you can comment briefly what we wrote in the German guidelines and also what is written on the EU guidelines on this topic. Matthias, it's yours.
Yeah, that's a very interesting question, because we assume that the bladder diverticulum or a pseudodiverticulum is a result of bladder outlet obstruction. But when you look in the literature, there's no proof for that. And the same is true for bladder stones. We don't know if bladder stones are really associated with obstruction. We assume it is, but it can also be diffuser underactivity. So therefore, we don't have these parameters as a game changer to decide either is it a good patient for watchful waiting, for drug therapy, or for a surgery. We assume, and maybe we are right, but there is no scientific proof on that. And I was amazed because I was working this up and I didn't find any. And I can mention this, by the way, we all know that acute urinary retention is associated with alcohol consumption, right? When you have a party and drink a lot of alcohol, you have a lot of patients with acute urinary retention. Look in the literature, there's not one evidence and not one line telling you that. So we have a gut feeling, and most probably it's right, but there's no scientific evidence. If there's no scientific evidence, we can hardly use it in guidelines because it's an evidence-based book or article. So I would not change my strategy because somebody has a big bladder wall, has a diverticulum. I would assume these are all the same type of patients. However, when he has a huge diverticulum, we may have to resect the diverticulum at the beginning. And I've got many patients who have no association with bladder outlet obstruction. So the young patients, 30, 35 or 40 with big diverticula without obstruction. And maybe they were born with this abnormality. I don't know.
Okay. Well, thanks a lot. Thanks a lot. There's certainly high-level evidence missing on this topic. There's no doubt about it.
No, there is almost no evidence.
Yeah. Okay.
No scientific evidence.
Okay. Well, the next question that came in, maybe it's something for Malte. And when you realize the slides, you see that the data are quite old. And the question are, do you have any information on newer pharmaceuticals that are being developed in the BPH area? Are you aware of any recent developments, probably going on in phase 1 or 2 studies? Malte, but probably also then to the other 2. But
yeah, I mean, of course, that's a brilliant question. So what we see, like even the prediction models we have, they miss some of the newer medications. I mean, newer like silodosin or also tadalafil. So this is something I think where the question is heading to. And if we look at novel targets and novel medications which are in the pipeline, are not really aware of something also from the congresses where I would say this is something which seems to be around the corner and where we can expect something, but maybe I'm missing those data, but I'm not really aware of something where we could say there seems to be a game-changing new class of drugs around the corner we may be using in future for our patients. I don't know whether any of the other panelists is aware of that, but I honestly am not really familiar with any of kind of newer, more promising developments.
Matthias shakes his hands, so he doesn't believe so.
Well, no, I completely believe so, because the latest drugs introduced in the male LUTS treatment were Madersbacher, the beta-3 agonist, and tadalafil, the PD-5 inhibitor. But then afterwards, nothing happened anymore. And maybe we don't have more receptors to target. I don't know. But when you look at the congresses, you will find primarily new operation techniques, minimally invasive operation technique, prostatic urethral lift, prostatic embolization, the water vapor. This is currently the focus of the scientific research in BPH, male LUTS. Okay,
thanks. A question for Paolo actually, and the question is: would you prefer a PDE5 inhibitor in patients with prominent prostatic inflammation and sexual dysfunction? And my question with this respect is, maybe I can add a comment: how do you assess prostatic inflammation non-invasively? So the question is how to assess it non-invasively, and do you think a PDE5 inhibitor is a good drug for these patients?
Yeah, thank you for this question, which is, I think, very clinically relevant. I believe that, data show us that tadalafil also have an important effect on reducing prostate inflammation. So in patients with prostatic inflammation and sexual dysfunction suffering from LUTS, maybe this treatment will be of course very useful and very effective. The problem is always to consider the severity of lower urinary tract symptoms, because in some cases, patients suffering from very severe symptoms who are significantly obstructed, probably tadalafil alone is not enough. Regarding the second question on how to assess prostatic inflammation, this is something really important. Of course, the only way to ascertain the prostatic inflammation would be to perform a biopsy, but this is something not always possible in the BPH context. So normally I would rely on symptoms, so patient's history, and also on something that is been controversial in literature, but it is an ultrasound science that has been associated with inflammations, which are lithiasis inside the prostate.
Okay.
I've got one question, Stefan. Can I ask Paulo?
And maybe not, because we are fair. Sorry for that. We have a fair amount of questions from the audience. So at the end, then maybe. Sorry for that. So this is a question to Malte, and it's coming from Austria. What is the best argument for maintaining medical BPH treatment, considering the increasing armamentarium? That's something Matthias always touched. Considering the increasing armamentarium of minimal invasive options. What would you tell a patient? What is the best argument for continuing this type of medical treatment? Malte, what would you say your patient?
I mean, if we look at the data, we can say that now we have a huge body of evidence related to the response and the effectivity of medical treatment. We also have long-term data, and many of the newer minimally invasive technologies really lack the huge body of evidence we have on medical treatment. And in the end, we honestly have to say that there are no studies which are comparing outcomes between medical treatment and minimally invasive therapy. So we have to be very precautious in suggesting that minimally invasive treatments are really a substitute for medical treatment, especially if we don't know whether further down the road the patients will relatively soon end up in taking medication again, maybe. So I think this is something where we have to really be honest to our patients, to look into the data, and to be skeptical what to offer them and what to promise them.
Mm-hmm, mm-hmm. Sure, I agree. The long-term issue and the validity of the data is a problem. So we have for medical treatment, we have thousands of patients in randomized trials with long-term outcome. This is certainly an argument that you can use for
medical treatment.
Okay, great. And thanks. A question for Paolo again, because you briefly touched this issue. Are there any updates on combining alpha blocker and anticholinergic treatments? Is there anything new?
Well, I'm not aware of anything new. We know we have on the market some drugs which combine together in one pill alpha blockers and antimuscarinic drugs. Honestly, in my clinical practice, I'm not used to suggest this kind of treatments. Most of the time, I use the drugs in monotherapy or two pills, I mean. Of course, as I show in my slides, there are some patients that will benefit from this treatment, but we need to carefully assess not only symptoms, but also the degree of obstruction, because as everyone knows, we could not suggest antimuscarinic drugs in patients with very high post-void residual volume.
All right. Okay. So I'm not aware of any very prominent new publications. Maybe I can. The next question is an interesting one. They're all interesting. Hello, this is a urologist resident from Ethiopia, though that's the good thing. So that we have the whole world around here. We have a lack of most medical drugs except alfuzosin and finasteride. My question is it possible to discontinue these drugs? Because in these countries, patients usually have to pay these drugs. And when shall we restart medication or proceed to surgery? And the second question is, how long shall we continue medical treatment? So maybe I will ask Matthias here. So the question is there a chance in countries where patients have to pay the drugs to discontinue the drugs? And when would you say, also with respect to these economical issues, when would you stop the treatment? So Matthias, please.
Yeah, that's a good question. The good news, number one, is you don't have to take tamsulosin and dutasteride. You can do the same treatment with alfuzosin and finasteride. These are the groups of drugs which you need to treat patients with a risk of disease progression. Number one, if this a patient if this is a patient with disease progression or high chance of disease progression, or due to max and all these parameters we have mentioned already, then it's certainly a candidate for combination therapy. And because finasteride or dutasteride work rather slow, you should take it at least 6 months. And in patients with a good symptom reduction, you can get rid of the alpha blocker afterwards. If this goes good, or if this goes well and the patient becomes asymptomatic or mildly symptomatic, you can continue until the rest of your life. However, if he progresses over time, then you should consider surgery. And when you see the risk of disease progression, acute urinary retention, and the need of surgery, yes, it's true that you can significantly reduce these chances. However, it's not zero. Even in the worst outcome, there's always a slight chance that you develop retention or you have disease progression, even though you use the combination therapy. Yeah, so the risk is not zero. It's decreased, significantly decreased, but it's never zero. And if he worsens, then with 5 alpha reductase inhibitors, I would consider surgery.
Okay. Thank you. Well, it's good to have somebody from Africa also online. Greetings to there. The next question, maybe to Malte. It's a drug we have not mentioned at all. The question is, does desmopressin still have a place in treating men with substantial nocturia?
Of course, I mean, nocturia is its own topic. And of course, if you see that the patient has nocturnal polyuria, which you can assess by doing the Rieken diary and some further tests, then I think it's a very valid and it's the very valid treatment of nocturnal polyuria. I mean, there's no question about that. And there desmopressin has a very prominent role. And I mean, nocturia is one of the most often overlooked, or let's say nocturnal polyuria is one of the most often overlooked diagnoses when we are treating nocturia. So this is something we definitely should point out. Yes, it has a clear place, no question about that.
But this should be a patient with really clear nocturnal polyuria and no congestive heart failure, with edema of the legs and a sleep apnea. It should be really an overproduction. Then it's highly effective.
Of course. I mean, this is what I pointed out, that you do the voiding diary and also additional tests to rule out that there are any other reasons for nocturnal polyuria. I mean, it has to be a true nocturnal polyuria, not related to secondary causes.
And you have to be very careful with the drugs to check for cardiovascular problems, to check the sodium regularly. But if you have such a patient and it's not possible to manage his symptoms otherwise, it is an option, I would say. But I think you have to be very, very careful in patient selection and follow up. But I agree with the guy who said it still plays a role. So a question now for again, I think for Paolo. What is your PVR threshold? It's an interesting question for prescribing antimuscarinics in men.
Yeah, basically it's the same as the EAU guidelines suggest, which is 150 ml. So normally, of course, in medicine, actually I don't really like threshold, because normally why we should consider 148 different than 152, but still it is something that we can keep in mind when prescribing antimuscarinic drug.
So you would suggest the 150 mLs, okay? Any other thoughts? I realized PVR on one of Matthias' slides in MTOPS they used a cutoff of 40 ml, which I don't think is really clinically relevant. So how would you answer this question? When would you be very careful in giving somebody antimuscarinics regarding post-void retrieval? Let's say if he is already on an alpha blocker.
Yeah. In the EU guidelines, it's an evidence-based guideline. So we look into the individual trials, and all the Astellas trials with the antimuscarinics with tamsulosin has been done with a threshold of 150, and we know it's safe. Maybe it's 200, maybe it's 250, but all the studies have been done with 150 threshold. So that is the basis of the EU guidelines. So therefore, if we believe in evidence-based medicine, we have to take 150. Of course, you can discuss is 155 a different thing than 145. We have to be a little bit flexible. But somebody with 300, I would not treat with antimuscarinics. But 150, I've got no problem.
Mm-hmm. Maybe I can ask here, Matthias, a question. Do you think that Betmiga is preferable with this respect?
Yeah, because it has no influence on the voiding function. It works in the storage phase. There have been two studies. They're showing a slight increase, but in general, there is no mechanism of action showing that it decreases detrusor contractility, because detrusor contractility goes via acetylcholine and not via beta-3.
Okay.
If somebody has PVR, I prescribe Madersbacher.
Yeah, I agree. A question for Malte, because we are just writing a paper on this topic. Having spoken on progressive LUTS despite medication as a possible indication for BPH surgery, what would be the role of alpha blockers and 5-alpha reductase inhibitors in the post-surgical patient?
Well, I mean, totally right. So what we see from the systematic review we are soon publishing or soon submitting is that there is really an increasing number of patients who are back to medication after BPO surgery. And this depends on the study you're looking at, but it's indeed year after year increasing. And what the studies have shown us is that when we think about recurring obstruction or persisting obstruction, these are the patients who are primarily back treated with alpha blockers, while we also have patients who have, for example, persisting storage symptoms, but this happens earlier post-operatively. So there are patients who are back on medication, but mostly the data seem to suggest that these are patients who have a recurrence of obstruction after a couple of years, if you think about the alpha blocker treatment. But the data which are out there, they are not really pointing out whether in the post-surgical patient, the medical treatment is as effective as in the pre-surgical treatment. This has not been investigated. So this is something where it seems to be kind of trial and error concept. But most of the patients who later on underwent, or many of those who later on underwent medical treatment, they ended up in having, it was a risk factor for additional secondary surgery. So,
can you just briefly describe on this systematic review which risk factors we have identified that patients receive medical treatment after BPH surgery?
So the risk factors we were able to see, these are mostly the risk factors associated with persisting storage symptoms, because this has been better investigated. And there we can see that older age, so usually older than 70 or 75, depending on the study, and especially stronger storage symptoms pre-operatively, and also diabetes, for example, which seems also to be associated with neurological aspects. These are some of the risk factors which are suggestive of a persisting need for medication post-surgery. And those, for example, who underwent alpha blocker treatment, that's a different story. These are primarily the ones who had the real persisting or recurrent obstruction, or let's say recurring adenoma, if you want to simply call it like that. So there we have to differentiate.
Okay, great. And we have, I think, 3 more questions here. There are continuously questions coming in, but I think we have to stop at some time point. One is a question for Paolo. Any role of specific subtype of PDE5 inhibitors?
Yes, so we have data actually not only on tadalafil, we have randomized trials also on sildenafil and vardenafil, but I think that the most effective drugs and the one that is currently only patent for this kind of treatment is tadalafil, because of its pharmacokinetic profile, which allows the once-a-day administration, which of course is something essential in this context.
Yeah, I agree. It's the only one where you have but we do have good data. Yeah, I agree. So it's tadalafil 5 milligram. Yeah, perfect, great. And a question for Matthias. What is the preferable alpha blocker as a first-line treatment? Do you differentiate alpha blockers? Do you always use tamsulosin as a first line?
Yeah, if a patient with male LUTS comes, there's always a reflex to prescribe tamsulosin. It's patent-free, it's cheap, it's effective. However, there may be some problems when you have a patient with arterial hypertension. The risk of force and fracture is significantly increased in the first 2 months of treatment. It's extremely expensive for the community, for the society to have it. So never forget to use it in the evening or night in the first 2 months. And if there's a patient very sensitive, you may want to change to silodosin. Or if he has a problem, you can change to tadalafil. And in the German reimbursement system is completely paid by health insurances. Even tadalafil, if there's a problem with tolerability.
All right. Okay. And do you also and tailor this depending on the risk of retrograde ejaculation?
No.
You think they all are the same?
No. Silodosin has a very high risk, and tamsulosin is lower, but it's still higher than others. Like doxazosin and terazocin, as Paolo showed, has the lowest risk of retrograde or a relative unejaculation.
Okay.
But this is primarily not the issue in the majority of patients with ejaculation, at least not in Germany.
All right. Maybe it's different in Italy.
It's certainly different.
All right. So we have one more. I think we finished now. We have one more questions coming from Livia. And maybe we will ask Malte to answer this. When do we start medical treatment for patients with mild symptoms? Do we really need medical therapy? And what to choose as a first line therapy in these patients? Would we choose monotherapy or combination therapy? So the question is really somebody with mild symptoms.
I mean, honestly, so if I have someone coming in with mild symptoms, we have to discuss whether the patient really wants to take a medication at all or not. Because depending also on his risk of progression, he may not really benefit from starting the medication early. For example, if it's someone who has a relatively small prostate volume, mild symptoms, of course, I would be very reluctant in starting a FAF-alpha reductase inhibitor. And because we know that also the effect of medication won't really kick in smaller prostates. So this is something where the first question is, do we indeed really want to treat this patient, yes or no? Because whatever we do has side effects. And it's also the question whether the effect of treatment, which also sometimes isn't that strong with medication, really balances the potential risks. But if you think about someone, and if you think about whether to start a monotherapy or a combination therapy, then of course this is also related to the potential of progression, and it has to clearly to be discussed with the patient. But I mean, the benefit of a combination treatment primarily is related to the faster onset of the alpha blocker. And if he has only mild symptoms and isn't really too strongly bothered by it, but has a higher risk of progression and wants to avoid progression, then a monotherapy with a FAF-alpha reductase inhibitor may also be suitable. So this is something where we have to be very precautious in not over-treating someone who doesn't really suffer too strongly from his symptoms.
My question would be, why does a patient with mild symptoms come to your office? Because I told you that the symptom severity goes along with quality of life decrease. The more symptoms, the more quality of life decrease.
Yeah.
But if somebody has only little symptoms but have a poor quality of life, there must be something behind. Is it the fear of prostate cancer? Absolutely. Or there is one symptom that is really bothering him, and we have to find out which one it is. And it's frequently nocturia.
Okay. Yeah. Okay. Maybe this will lead us to now really the last question. And because you mentioned prostate cancer, in a patient with a life expectancy of less than 15 years, well, if you are able to predict this, is measuring PSA necessary in the initial evaluation? Well, I would say no, because you can use prostate volume. So I would be very, very reluctant in doing that. But this is, you agree?
I agree.
Yeah. So, well, I think we got a fair amount of questions. We had a very, very nice discussion. I would like to thank the attendees. I would like to really thank the faculty for giving good talks, which obviously stimulated a lot of discussion. And I think I will end up the seminar, and I will thank once more the ASU for organizing this, and also the sponsor GSK for making this possible. And I wish everybody, wherever you look from the world, and now at least in Middle Europe we have now evening. I would like to everybody now a nice evening, and thanks for joining us. And I think it was a great webinar, and it was a pleasure for being with you. Thanks a lot and good night. Bye bye.
Thank you very much. Take care.
Thank you. Bye.
Thank you. Bye bye. Thanks.